So thank you for having me. An AAEP survey suggests that 87% of equine veterinarians in America use biologics of some sort. We can talk about autologous orthobiologics like PRP, but Arthramid is also considered a biologic. I was recently teaching at Arthrex in Naples, Florida, and we took a survey of how many small animal people, it was all small animal surgeons, residents, faculty, and 60% of those folks attending that, and there were probably 200-ish, of those small animal folks are using either Arthramid or other biologics for their joint injections as well. So that begs the question of why do we inject joints? And there's a fair number of reasons why we do, and I'm just trying to be a little thought-provoking here to say, do we inject them because you perceive there's a stiffness, a lameness? Are they not performing very well? But have you really localized the lameness to that area? In America, it's quite common just to do maintenance. It's spring for my horse. They're like, would you like your horse injected? I'm like, nope, it's not lame. So it's really, really common in the spring and the fall in America to just lube the joints and inject front fetlocks, hocks, depending on what the discipline of the horse is. Do you see on an x-ray, right? Maybe it's not even clinically proven to be the site of the lameness or the perceived lameness, osteophytes, enthesiophytes, DJD, arthritis, whatever you want to call it. I think I have a couple, and then post-surgery, of course, as well. So then that's the why might we inject a joint, and what do you inject them with? I think the most common thing would be corticosteroids. I've given several talks to horse racing industries. I'm part of HISA, the Horse Racing Integrity Safety Assurance, which is in America, is regulating. It was Congress mandated 5 years ago that every thoroughbred race track would have to be part of HISA and abide by our rules. Otherwise, you can't have off-track betting, and that's the only way the racetracks are surviving in America is OTB. So I've given these talks too about, because corticosteroids are almost banned in those horses. So what are some of the autologous orthobiologics, and then polyacrylamide hydrogel? And then if you know why might we be injecting it and what are you injecting it, are you actually thinking about, is it too late? What's the disease stage? Are you injecting it in this early stage of osteoarthritis where maybe the cartilage, this is actually a humeral or glenoid humeral, when it's actually quite normal. Maybe there's no osteophytes or enthesiophytes, which we know aren't sensitive markers of osteoarthritis anyway. And then there's all the normal, this is normal histology of articular cartilage, and we have this whole range until you get over to bone-on-bone osteoarthritis with these large osteophytes, probably mineralization of the medial meniscus, and degradation, proteoglycan loss of cartilage. Even in that right-hand articular cartilage, almost nothing percolates through cartilage. There's something called like the conglomerated network. I just love that word. I don't know, any engineer knows like it's a way to study percolation of size and molecule and lipid structure and those sorts of things through different structures. And almost nothing percolates through cartilage, even when on the right-hand side, including corticosteroids. So don't think that you're treating articular cartilage when you are injecting a joint. When you're really putting stuff into a joint, what you're primarily treating are the soft tissues, the joint capsule, if the joint does have a cruciate ligament, a meniscus, or a patellar ligament. So remember that every time you stick something into a joint, including if you're blocking the joint, you're blocking all of those structures. But you are not blocking subchondral bone unless there's exposed bone, okay? So if a horse has intact articular cartilage, a racehorse has intact articular cartilage, you block the fetlock, and it does not respond. That does not mean the lameness isn't in the fetlock. It's probably just in the subchondral bone, which is where we know most of the disease starts in the racehorse anyway. Already said that. A case in point to prove some of this, this is really teased out in a couple things. We know from old literature when we were trying to figure out where joint pain is and patients were under a scope. If you're scoping a joint and you ask your anesthetist, watch that horse, and just jerk on the joint capsule, and their blood pressure will go up. They might react if they're under light plane of anesthesia. Jab the articular cartilage and they won't care. So, we just know that the pain receptors in the joint capsule is where the action is. Many of us have done these biphasic cultures where we can tease apart and try to model the articular joint. So in the base of these wells are the synoviocytes, meant to be from the synovial membrane. And in the top, there's chunks of cartilage. This is one that we did on, so we got knees from humans that were undergoing total knee arthroplasty, and we took what cartilage was left. So this is pretty degraded articular cartilage. And there's synoviocytes, which are not happy in that picture because they aren't happy in an OA joint. And then we can do this to try and tease apart like who is receiving this treatment, who's responding to a different treatment. And what we did was a control, which was basically culture media, ACP, which is Arthrex's leukocyte-reduced platelet-rich plasma, and then we had hyaluronic acid. We also had corticosteroids in here, but steroids killed everything. I mean, it killed everything. That doesn't happen to normal cartilage in tissue culture, but these aren't normal cells. So remember that when you're reading studies too, if they're looking at normal cartilage, normal synovium, that's not the same as these cells that are already primed to be self-destructive. So what we found was in the upper right-hand corner, you can see that TNF-alpha is a very sensitive marker for pain. And in the control, so you want less TNF-alpha. And you can see that the ACP, which has a B, and the HA are the same. So they significantly reduce pain. Platelet-rich plasma and hyaluronic acid reduce pain. That's in the synoviocytes. All three of these graphs are in the synoviocytes because nothing happened in articular cartilage. It was alive, but they didn't respond at all to either the control media, PRP, or HA. Hyaluronic acid produced in the synoviocytes was increased by PRP, but not HA, right? HA we know is anti-inflammatory. Some people say it lubricates the joint. That's pretty old school. And then MMP13, which degrades normal intact cartilage, was quite decreased by ACP, but not HA or control. So the whole point of all this is to say the action is in the synovial membrane. The action of whatever you're treating with is not in the cartilage itself. So that's one thing to consider, that remember you're treating the synovial membrane whenever you're injecting something. The second thing is many of us were taught that osteoarthritis is not an inflammatory disease. And that's been proven wrong for the past 10, 20 years, but most of us don't read that basic scientific literature. And it's actually considered immune-mediated disease, but for many, many years we segregated those into, that's rheumatoid. We didn't use the word immune or inflammatory because that suggested rheumatoid, but we know osteoarthritis is immune-mediated. And then again, we're seeking immunomodulatory ways to treat the synovial membrane. I won't bore you with all of this. The point is that there are many, many immune cells. On the left-hand side is the average of the number of immune cells in normal synovial fluid, and on the right-hand side are the immune cells in osteoarthritic fluid. These are a combination of animal model studies and human naturally occurring arthritis. I think Jason's going to talk more about macrophages. So most of us thought macrophages were like Pac-Man, right? They ate whatever was around. But we now know that macrophages go from M0, which is their resting state, and this is an oversimplification, and then they can go to M1, which is pro-inflammatory, so they feed into the inflammatory cycle, and they can go to M2, which is reparative or functional tissue regeneration. So we want to seek immunomodulatory things that shove things over to the M2 phase, which is what part of what Jason's going to talk about, so I won't spoiler alert. The other immune cells are the T cells. So a lot of times we think of these as like in allergies is what many of us were taught. But the T cells are also very, very important in immune modulation. It was a big focus of my research in my laboratory, so I'll show you a little bit of that data without boring you. The other thing to look at is the range of these cells, right? We all know most of us in this, or half of us in this room probably have arthritis. You have good days, you have bad days, you have good mornings, you have crap nights. So it's really undulating. And so are the ranges of these synovial cells. So trying to figure out when to target that timing is, so you want something that's long-lasting as well. Because of that range in naturally occurring osteoarthritis, and there's lots of things, age doesn't mean you're going to get osteoarthritis. There's lots of things that play into that, genetics, nutrition, how much exercise you do, all kinds of things. But what we do in the laboratory to try and study osteoarthritis instead is to try and deconvolve all those complicating factors of naturally occurring OA and study PTOA or post-traumatic osteoarthritis. So this is a little schematic of like the ankle is the easiest of the joints to study this in because it doesn't have a meniscus and all these other things. This is just a little schematic of how osteochondral lesions happen in the ankle if you have a really severely sprained ankle what you do is bang the chondrocytes in the subchondral bone, which is important, and that sets off this whole reaction. And it might not be till years later that, if you have a bad rugby injury or whatever it is, it might not be till years later that you develop osteoarthritis, but that's a different mechanism than age onset. In the horse, Murray Brown. What's that? Murray Brown from Florida. That was kind of fun, though. Anybody else, Murray? They developed this model of post-traumatic osteoarthritis so that we can, we don't want to euthanize horses, right? So we want to study things that we can study reversible disease. So Murray Brown and colleagues developed this model of reversible post-traumatic osteoarthritis in the horse. So they basically created dorsal medial P1 chips that we see all the time in our thoroughbred racehorses. And we know when you take that chip out, they go better, right? So now we can study post-traumatic osteoarthritis in these horses, take the chip out, and the horse can go on to live its life. So it's not a terminal study. So this is a really, really cool way to study post-traumatic osteoarthritis. In humans, probably the most common thing for post-traumatic osteoarthritis is ACL rupture, very common in all of our sports. The work from Christian Latterman and his group on the right-hand side, he discovered the first true biomarker in osteoarthritis. Again, deconvolving the system, so it's not age onset, you have this specific subset. And these are young players that came to him when he was at the University of Kentucky. He was the team doctor. So what he did was to take synovial fluid at the time of injury, then he injected them, drained the knee. He took synovial fluid at the time of surgery, 1 week post-op and 4 weeks post-op. And then they did proteomics and looked at all the different proteins that are in the synovial fluid. And the biggest one that stuck out, nice. Let me just, the biggest one that stuck out was interleukin 6. And there was this cutoff point where if you had 316 picograms per mil seemed to be the cutoff point for IL-6. So if you had more than that, you were a non-responder, meaning he fixed your cruciate ligament, you got HA and whatever else the other things are. But if your IL-6 stayed high in your synovial fluid, you got osteoarthritis. If your IL-6 went down below 316, and that was just dot plots, and you're like, these guys got OA and these didn't. They were called the responders. So if your body somehow figured out how to resolve that inflammation, get rid of the IL-6, you went on to be a responder and you did not get osteoarthritis. That's probably the first true biomarker. This IL-6 was increased in the serum and the synovial fluid. We also know from IL-6 that if you put IL-6 into a joint, that you get osteoarthritis. And it's increased in lots of models of PTOA, including that horse model that I showed you. We talked about the undulation of osteoarthritis. So there are IL-6 recombinant antibodies, right, that you can give that are made for other immune-mediated diseases that doesn't work in osteoarthritis, probably because of this undulating, cascading event in osteoarthritis. Maybe if it was injected earlier, but the clinical trials where it's been tried, it's a little bit too late. So that's lesson number 3, inject early. This is a really common concept that we think about now, is this natural inflammation that we all learned about. So you have inflammation at the time of injury, and that's when the neutrophils come in. And then you have this cell proliferation and some remodeling, and which is replace the macrophages. Again, you want those to, they'll come in as M0s. From monocytes to macrophages, they'll be M0s. You want to push them towards M2s. And that's in the tissue formation. And then as you get into tissue remodeling, that's when your T cells come in. Again, an oversimplification. But what we want to do is let nature do this, but figure out how to stop these from overlapping, stop them from becoming too long. So let nature go through its inflammatory process. All of these stages are really important, but can we shorten each of them to optimize our outcome measures? What happens in pathologic inflammation, and I should say that, again, the canary in the mine, that synovial membrane in a normal joint, you can literally see capillary, blood, like blood pulsing through the capillary. It's like looking at an anemone. It's so nice and thin. When you have pathologic inflammation, that's what your synovial membrane looks like. So that is truly the proverbial canary in the mine. What we don't want to see in an articular joint, and this is what leads to osteoarthritis, is any of these phases of inflammation getting prolonged. So it could be the early inflammation stage, neutrophils are around too long, or if you're using platelet-rich plasma, we don't use one that's high in neutrophils because you don't want to reinstigate this disease. And the tissue formation would be your macrophages, and again, scar tissue formation are the T cells. So in this little schematic in the lower left-hand corner, you can see when you have osteoarthritis, the scale tips down, and you get more of these Th17 cells, which are pro-inflammatory. They secrete IL-17 and IL-6, and then you get that vicious cycle. So you get IL-6 coming back, you get more M1 macrophages, you get more Th17 cells, and then you get, again, M1s, they secrete IL-6, and it keeps going. And there are other cytokines. But what you really want to do is shove it back this way. You want to produce more M2 macrophages and more T regulatory cells. That's how you get functional tissue regeneration. Taking that study that I showed you from Murray Brown, we looked at our horses these are cases that I operated at Cornell with a dorsomedial P1. And we categorized them as, they all, by definition, have post-traumatic osteoarthritis because they have a traumatic incident in the joint. So we called them mild post-traumatic osteoarthritis. In this picture here, if you took the osteochondral fragment out, but the cartilage around it was perfectly normal. Palpated normal, it didn't have any fibrillation, it wasn't thin. Joint capsule looks normal. Most of the time, if you're struggling to find these, you know you can just look and find the red synovium and lift that up, and there's your, or the plantar P1s that some people struggle to find. Like, just follow the red synovium and you'll find your chip. And the rest of the joint can look quite normal. And then we called these moderate PTOA. You can see where the chip was removed, but there's fissures and others, damage to the articular cartilage in the surrounding area. And we went back to the laboratory and looked at these T cells. Again, lots and lots of, I'm not underplaying the role of macrophages, but lots of other people have looked at them, and T cells are really understudied in osteoarthritis in all species, not just the horse. And the first time ever, we showed that these T cells undergo a phenotypic switch. So the cells that should be, that one in the upper right-hand corner, that FOXP3, that should be secreting IL-10, but it's also secreting IL-17. So it's kind of this hybrid cell. Its master transcription factor, we know, so that tells you, oh, you are a T regulatory cell. You're expressing FOXP3, but you're secreting both pro and anti-inflammatory cytokines. So again, the concept is immunomodulation. How do we get these cells to go back to M2 macrophages? How do we get them to go back to T regulatory cells? And that's where we need to get to, not just squashing inflammation with corticosteroids. So the goal is immunomodulation of the synovium. Other than intra-articular injections, there's other ways to do this. Cold hosing? I don't think so. Like, I tell people, like, stop doing that to the environment. We know from many, many studies that from thermistor probes that it doesn't even cool to the depth of the skin. So just stop wasting water and on the horse's leg. If you have an EQ press or something like that, that's fine. But I get a little crazy when I go to my own horse's shows and they're all like cold. But at least they're looking at the leg. That's how I look at it. If they're standing there cold hosing it, at least somebody's looking at it. Lotions and potions, I love Surpass. Do you have Surpass here, diclofenac? Yeah? Voltaren, yeah. Yeah, for me, like, I got through a marathon with a pulled calf muscle with Voltaren. It is really magical. If you have hand arthritis or anything like that, I would strongly suggest that you use it as well. But topical diclofenac, lots of external stimulators. So this is the concept we were talking about earlier about these are athletes. Manage them as sports athletes. So think of all these combinations of things that we can do: shockwave, lasers, EQ presses. Encourages lymphatic drainage, so it squeezes from the bottom up and has cold as well. Corticosteroids, and then the biologics and nutraceuticals, supplements. There's actually a really big growing trend now to, sorry, Kat, if I'm going to insult a internal medicine person. I have a chunky monkey horse, like on the verge of like getting dimples. So every spring, at least every spring, and I think every horse every spring should have an insulin level test. Because I think a lot of horses are on the metabolic spectrum and we don't recognize that. Is that fair? It's like when there's an engineer in the room, I'm like, oh no. So I'm sure everybody in this room does use corticosteroids. Fortunately, it never really caught on in dogs, so hopefully we can get most of the dog vets to go straight to biologics, or at least biologics is a broad category. So we know that the corticosteroids are certainly a very potent performance-enhancing drug. They're super inexpensive, easy to use because they're off the shelf, and oftentimes I think we're treating the client, right? It's doing something, you're injecting the hocks to get that horse to go better. So it's not necessarily treating what the joint is. The cons are also that it's a potent performance-enhancing drug. Drug testing is a real problem. We've got some real shady people in America. They're always getting busted for, ooh, it was a topical cream for my horse's dermatitis. Probably everybody remembers that and got your name removed off the plaque for that one. And you lost your $1 million purse. And this is really, as I said, for this HISA, this horse racing integrity safety assurance, I mean, it's going to be femtomolar amounts, and it's zero tolerance on race day. So corticosteroids are going to be a real problem. And even though we know drug withdrawal, some horses don't clear it as fast as others. So this is going to be a real problem for some people. Steroids have zero protective effects compared to all the other things that Jason and I are both going to talk about. And most people don't. How many of you guys have had a steroid injection yourself? Anybody get euphoric? No? You didn't? Maybe it's a woman thing. Steroid euphoria is real. I'll vacuum your curtains if I have a steroid injection. That's why, at least in America, we say no dog should die without the benefit of corticosteroids. That's steroid euphoria, and this happens to our horses. Little comedic humor. So it'd be really common, right, to inject the horse's hocks. Owner says the horse never went better, but they wore off after a couple weeks. Can you give them again? So the horse just got stoned, which in some cases is okay if the horse isn't actually really lame and the owner just needs to get over it themselves and to ooh, now my horse is going better. Now maybe you're moving and they strengthen their muscles and all those things. Maybe you can at least get them to buy into rehab and say, wait, I just injected your horse. Now you really need to adhere. I'll only inject your horse if you adhere to my rehab program. So they do have their place, but if they come back and say, oh, my horse went great for 4 weeks, can you do it again, doc? I'm like, your horse just got loaded. So what is better than steroids? Pretty much everything. Biologics for sure. Some of the biologics that I'll just touch on, because each one of these could be a 5-day seminar in themselves, would be platelet-rich plasma, IRAP. Do you guys have IRAP here? Prostride? Wah, wah. Stem cells, A2M, and the polyacrylamide hydrogels. The advantage of these is that they also are off the shelf. They're obviously more fiddly to make. See if my little movie will play. Is that playing? Yep. Oh, good. In contrast to corticosteroids, they have reparative effects through their growth factors. And if you don't use one that has stem cells like platelet-rich plasma, we know that those growth factors in PRP and in IRAP actually recruit stem cells, and that's what's playing in that movie. So in the middle, all these stem cells started out in the middle chamber, and there's plenty of food, there's plenty of space in there, they don't have to migrate. And then we put different things on either end so that we can check for potential migration. And the green swirly at the bottom there is MSCs preferentially and directly migrating towards platelet-rich plasma. And in the orange, they just vibrate back and forth when they're just going towards fetal calf serum, which is quite potent cell proliferation. So even if you don't give a biologic that has growth factors in it or that has stem cells, we know that it will recruit local stem cells as well. There's a super low regulatory burden to biologics in America. They're a device. It's not a drug. You're not licensing the platelet-rich plasma. It's the plastic thing that you're spinning it in that is registered. The disadvantages are the variability, and this is really frustrating, and we don't know what optimal is. There's variability within the product, within platelet-rich plasma, but also patient variability is a problem as well. We don't know which one is better, but they're totally fine to use. There's no withholding time for these for the biologics. So I've said most of this already. They're regenerative and anti-inflammatory, not just hitting everything in the world like corticosteroids. From the human literature, we know that PRP works better and longer than triamcinolone for what's called Kellgren-Lawrence grade 2 and 3, so mild to moderate osteoarthritis in humans. And it's not a drug. And the World Anti-Doping Association does allow these biologics as well. At first, they banned them because they thought it might be blood doping, right? Because they're blood-derived orthobiologics, but then they reversed that. And I would say this about all the biologics, including steroids to a lesser effect, biologics, including Arthramid, these aren't a miracle. Don't wait until everything else fails. Oh, wait, steroids failed, so then I'll try PRP, and then like, well, PRP doesn't work. Well, if steroids didn't work, these other things aren't going to work. The concept is that you have choices, and you have choices that can affect the long-term health of the animal's joint. At least in America, like the ACP syringe for Arthrex would probably be only $25 more than a bottle of steroids if you use a fresh bottle for each horse. So it's not a huge cost discrepancy. The questions that come up all the time for the biologics is which one's best? You have options, is what I will say. Which one's better for OA, for tendon, ligament, meniscus? Do I treat in the acute versus the chronic stage? That's an easy answer. Treat as soon as you diagnose don't wait. Don't even wait for them to go through rehab. You don't want to start injecting joints or tendons once they failed rehab. You should inject them and get them through your rehab program. How many injections? I think I have a slide to talk about that. Best dose volume, we don't really know that yet either. And in human side is all they really want to know is how do they get reimbursed for doing this. Obviously, we're a cash practice. So platelet-rich plasma, again, hundreds and hundreds of ways to make platelet-rich plasma. Lots of different theories out there. In my opinion, in the research that we've done, it's not just the growth factors. We know that more is not better. We know a dentist with the last name of Marks, probably 20, 30 years ago, came up with this idea that a 4-fold increase in platelets was about right. So that means if you started with 1 platelet in your blood, 4 platelets in your PRP was the right concentration. Turns out he's pretty right. And there's no research, you can go back and read his original paper. There's no way to know how did he pluck that number out. There's no reference. PRP started in the dentistry world for like slow healing tooth extractions. So lots of different growth factors. Again, they just plateaus out, so more is not better and actually can be detrimental to some tissues like meniscus and some others. And I would strongly encourage that you use a neutrophil reduced PRP. You can get leuko reduced, but mostly what you want to ask the company is how many neutrophils are in your product, right? Remember the inflammation cascade. You don't want to go back and incite inflammation. Might be a little bit different if you don't get to see a tendon until it's really chronic. Then maybe you want to put the neutrophils in and kickstart the healing cascade. But in osteoarthritis, there's no evidence that you should use a product that contains neutrophils. So at least neutrophil reduced. And we know that neutrophils they secrete tons of MMPs, interleukin-1, which everybody would know. So they're very pro-inflammatory. They also decrease our regenerative things like tissue inhibitors and matrix metalloproteinases. So there's really no scientific basis in a laboratory, in human testing, or conceptually to use a PRP that has a high concentration of neutrophils. How many injections? Some people say 1, some say 2, some say 3. This is what I do in my practice. This doesn't matter if it's a tendon or a joint or what the substance is. I give a first injection, and then I try to see them 10 to 14 days later. If I see no response at all, meaning, let's say it's a lame joint or an inflamed tendon, the sensitivity to palpation is the same. They're equally as painful. They're equally as lame before and after flexion. I never do a second injection. I don't think, if they aren't going to respond at all the first time, I don't think you're going to get a response. Maybe you missed the diagnosis. Maybe it needs surgery. Maybe it's just time to find a different career. But I think there's, that's just my philosophy. After the first injection, if I see a response, and I softly say 50%, if you're 50% or more, I still typically don't give you a second injection. I'm like, just stick to the rehab and come back. Lots of times people are going to say, can't you just please inject it? But I've treated and euthanized enough horses with infected joints. I don't want to be injecting things that I don't have to. But if I do see a response and it's like little bit less than 50%, but I'm convinced I got a response, and I will give a second injection. Again, if it's into the tendon lesion or into the joint, very rarely do I need to give a third injection. It's just that rare. But try to get them every 10 to 14 days so you can keep going in the same direction. IRAP, IL-1RA, orthokine, regenikine, made famous by lots of great athletes. So popular in America, you can see this horse is Silk. His name is IRAP. So he came into the clinic and bay horse like 99% of the thoroughbred race horses. And because they don't have a name at the time, and the farm manager just put a loop around the horse's halter that said what they were going in for, and this horse was coming in for IRAP. So, and it worked apparently, so they named this horse IRAP. He also has a nasal band on that tells you how scientific they are. I think this is still a great product, but the overnight incubation is a problem, right? That doesn't make it stall side anymore. And this bans it from use in humans because that's more than minimal manipulation of blood. So at least in America, you still can't use anything like IRAP because of this incubation period. So then, so we all know that IRAP, I think we all know, IRAP works by outcompeting interleukin-1. So you need more IRAP than you need IL-1. And then it binds to the cell surface, and IL-1 floats around and can't have its effect. So because of that overnight incubation period, along comes Prostride. So Prostride is basically platelet-rich plasma that then is incubated with these polyacrylamide beads, but you can make it in a little bit shorter time period. So this can be stall side. It does have more IRAP than PRP, but nowhere near the amount of IL-1RA that true IRAP with the overnight incubation has. So it's better, but in America, this is really expensive. So I am a consultant to Arthrex, just redisclosing that. So instead of that, if I think the patient, if I perceive that the patient needs IRAP, then I'll use Arthrex's Pro-Ease. It's the same concept. It's just a shorter incubation period. So the beads are a little bit different. They're a polystyrene, not glass. And then this is a little graph that I put together from Prostride. The real IRAP, the overnight incubation IRAP, and they call it IRAP Pro-Ease. So the volume that you get, from Prostride is so minimal for a lot more money. So this is coming mostly gone in America, at least on the racetrack. And the cost of the kits, and the kits that's per picogram of IL-1. So if you really want to get a volume and a lot of IL-1RA, then either really use the real old-fashioned IRAP, in which case you can freeze it, right, and then redose them later, or IRAP Pro-Ease. I've used Prostride. I just don't love getting only 2 mils for that amount of money. Stem cells are, did anybody culture stem cells over here? Alana's like, I'm actually working with Thomas Koch. Some of you might know him in Guelph. He's trying to go the FDA route to get umbilical cord cultured stem cells truly FDA approved. So GMP facility. He's really trying to go the full route. Another fellow Kiwi, Wayne McElraith, is also on that scientific board. So the old concept of stem cells was on the left here. What we used to think is if you took a stem cell, it actually turned into the tissue type. So it turned into a chondrocyte, or it turned into a tenocyte. And that's been shown wrong for like 40 years. But that's an easy thing for us to say to our clients. Oh, I'm going to inject stem cells and it's going to regrow your cartilage. But that's not how it works. Stem cells work by these little puffs that I have coming out on the right-hand side. And these are bioactive factors. There's millions and millions of things that the stem cells secrete. In fact, dead stem cells will secrete these same things as well. So you don't even really have to have live stem cells. And what that does then is recruit stem cells to the area, stimulates angiogenesis, all kinds of things. So that's the way we should be thinking about stem cells. Is this whole thing that's secreted out of the cells is called the secretome. This is a little schematic I made to say that. So the blue are the cells, and then the red and green and blue and the little blue squigglies are all things that are secreted out of the cell, and they all have profound immunomodulatory effects. They have these exosomes and microvesicles. These are all bilipid membrane vesicles that you can see on scanning electron microscopy, and you can see a little one there. And there's a huge race towards official secretome. Hilltop Bio is not an official secretome yet. In fact, I would say, I don't know about your regulatory body, but in America, and last I knew around the world, there are no real secretome products. I would say this in America, hard stop, period. There just aren't any. There might be people that are saying they have them, but secretome, because they're part of stem cells in America, will be a drug. They have to go the drug pathway. Remember I said the other things are a device. So there's nothing at the FDA that is saying we have a secretome product at our hand. So if somebody's trying to sell you a secretome product, ask them, can you see them? This is, again, a transmission electron microscopy. These things are tiny. So on the right-hand side over there, you can see the little bilipid membrane. So that's cool. That nanocyte thing in the upper right-hand corner, you put your solution in there, and it should give you these peaks at the right size. So you think, ooh, I have my, I made secretome. I have microvesicles. That was my first attempt, and I was like, I'm a genius. I made secretome. It's actually PBS. It's saline. When the student brought it to me, I was like, look at that. That's so cool. So you have to, so don't be fooled if somebody brings you a graph like that and says they're the right size, so we have secretome. You need to see them on TEM. Secondly, are they biologically active? It doesn't really matter if you have them if they're not active. There are ways that we're going to, in my lifetime, we will see secretome, and it'll be off the shelf. It'll be a lyophilized product. And I think that's going to be one way that's going to revolutionize a ton of diseases. Cancer therapy, lots of different things for secretome. So this is really exciting. And in America, then, if somebody's trying to sell you secretome, there might be a clinical trial with somebody trying to get it through the FDA. Then you want their IND and their IRB number if somebody's trying to sell you secretome. A2M? Yeah. It never really caught on in America either. It's basically dehydrated blood. So alpha-2 macroglobulin is a potent anti-inflammatory known to be anti-arthritic. So basically you put it in there and it dries out the blood a little bit, so that's how it concentrates the A2M. Some people love it. I never used it. And it just never really gained the popularity that stem cells and PRP and some of the other things did. And I want to just end a couple things with some other concepts, like all biologics are complicated, and this is a problem. Like we talk about, ooh, these growth factors, PDGF and others in PRP, but there's tens of thousands of proteins and lipids and other things in all of these biologics, whether it's IRAP, A2M, PRP, stem cells. So you can't just pin it on one thing. They're really complicated. It gets even worse in human medicine if they're smokers, if they have diabetes and all these other things. So it's just really complicated, and that's a problem. So that's a problem that at the end product is variable, but it's also the patient variability, and we're just starting to understand that more in humans. Again, how much did you exercise before you came in here? What did you eat? Are you dehydrated? Are you a smoker? Did you drink a glass of wine? Did you just get off an 18-hour flight yesterday? All these things can really, really add up. So here's some of the latest human data. Smoking, obviously, but you know, we all know this, right? We all have different reactions to different drugs. So this personalized sensitivity to drugs and platelets is really pretty cool. We know that your platelets line a lot of your blood vessels. So if you just do a short burst of exercise, you get many, many more platelets in your platelet-rich plasma. So some people, before we knew that more wasn't better, would have you get on an exercise bike for 5 minutes and go to VO2, whatever it was, and then pull your blood so you got more platelets. But we now know that more isn't better, so it doesn't really matter. We're getting close to Jason now because all these things are coming into the idea of one way to get around that variability is to use a biologic like polyacrylamide hydrogels. In my clinical practice, I think that's what's next. In my clinical practice, when I first started, I used these when biologics failed. And primarily that was in the coffin joint and in the stifle joint. And most of the stifles now, I can't get stifles into an MRI when it's still attached to the horse. So I typically do ultrasound to see what the cartilage on the trochlea in the femoral condyle looks like. But these used to be the cases that I would reserve it for. In my practice now, what I do, once you've localized the lameness to something, I'll use an autologous blood product, usually a LUGO-reduced platelet-rich plasma, and I'll inject the polyacrylamide hydrogel, follow up with platelet-rich plasma, because the polyacrylamide hydrogels take a little while to take effect. My personal horse has had Arthramid in his coffin joint 3 years ago. So and he's still doing very, very well. I think that's a downside of the product. Like, it's not like biologics and other things that you're going to have to you might have to continue to re-inject. And none of this is going to work without a really good rehab program. I mean, the people that really know rehab are fascinated how to activate one certain muscle, and I'm not that person, but I'm sure you have really cool equine and canine rehab people here, and I'm super assertive with this. I'm very aggressive with rehab, and I don't tell them, I tell them this is what you're going to do for the next 2 weeks, and then they're like, well, then what? Then I'll tell you when you come back. Because if you send them home with this, they never come back. They'll come back at 24 weeks, and you're like, well, you were supposed to come back at 2 weeks. What happened? Well, I just kept I thought we were doing okay. But I'm pretty assertive with the rehab. So the take-home messages are, you have options. Treat very early in the disease stage. Don't wait until, again, rehab has failed. And case selection is super important. You think, is surgery indicated or is it just too late? And this is a shout out to another medicine, like check for metabolic and other things that can be affecting the performance of that animal. Happy to take any questions, or do you want to go first?
All right, any questions?
No questions?